Hello, everyone. I'd like to thank SAGES for allowing me to present our study on the impact of minimally invasive surgery on post-discharge outcomes following distal pancreatectomy. I had nothing to disclose. So as most in the pancreatic surgery field know, in 2009, the LEPER trial was published. This is a randomized controlled trial from the Netherlands evaluating a minimally invasive versus open distal pancreatectomy. In the study, patients who underwent a minimally invasive approach had improved patient functional recovery and quality of life at 30 days, but there was no difference in complication. What went a little bit unnoticed in the trial is that they had a very high hospital readmission rate at 90 days, in which more than 1 out of 4 patients was readmitted to the hospital. So this is what pushed us to perform a study evaluating what was the impact of the surgical approach on post-discharge outcomes. So in our study, we evaluated the extent to which minimally invasive surgery impacts on post-op hospital readmissions and emergency department visits following distal pancreatectomy. Secondarily, we also wanted to identify peri-op variables associated with these outcomes and verify how minimally invasive surgery impacted on functional recovery. We evaluated a consecutive series of 376 patients who underwent distal pancreatectomy between 2012 and 18 in a single high-volume center, which is San Raffaele Hospital in Milan, Italy. During the study period, all patients were treated with the same peri-op protocol, which is an enhanced recovery pathway. We looked at unplanned hospital readmissions and ED visits at 90 days post-op. Time to functional recovery was defined as a recovery of GI function, recovery of a sufficient caloric intake, restored mobility, and an adequate pain control with only oral medications. We defined our pancreatic fistula and hemorrhage according to ISGPS definitions, and we used the Clavia and Dindo classification for complication severity. Data was collected in our Division of Pancreatic Surgery registry, and we compared outcomes between laparoscopic and the open group. We performed regression analysis to evaluate the independent impact of the different variables on our main outcomes. So out of 376 patients, 244 initially underwent laparoscopic surgery, but 7% of them were converted to open. And being this a retrospective study, we used a per protocol analysis. So these patients were shifted in the open group, giving us a total of 219 patients in the lap group and 157 in the open group. So looking at baseline characteristics, you can see that in the open group, we had patients who were older, and this was mostly due to the indication to surgery because most patients with pancreatic cancer were still operated with an open approach, while a greater proportion of patients with a benign tumor, such as neuroendocrine tumors or benign cystic neoplasms, were treated with laparoscopy. Looking at operative data, you have more patients who underwent a more extensive resection, including major visceral resections in the open group and vascular resections as well, compared to laparoscopy. And this obviously translated in higher blood loss and need for blood transfusion during surgery in the open group. Look at time to functional recovery. You can see that the median time to functional recovery was shorter in the lap group. Actually, the median is 5 days post-op in both groups, but you can see that the 75th percentile is 1 day lower in the lap group and is significantly lower. And also, if you look at the mean time, that is lower in the laparoscopic group. This definitely is due to a faster tolerance of the oral diet and also a more adequate pain control with oral analgesia in the lap group compared to the open, and is translated in a 1 day shorter length of stay in the lap group. Looking at post-op complication, here we splitted this table in complications who occurred during primary hospital stay and those who occurred finally at 90 days after surgery, and you can see how clinically relevant pancreatic fistula was occurred in around 24% of patients during primary hospital stay, but this goes up to 46% at 90 days after surgery. This is mostly because of the new ISGPS classifications in which patients who keep a drain for more than 3 weeks, despite being asymptomatic, no fever and anything else, shift into the grade B fistula from a biochemical leak. And so this definitely raises the overall complication and should be taken into account when looking at this data. Also, you can see how the most important complications that increased at 90 days is infectious complications, especially intra-abdominal abscesses. If we compare between open laparoscopy, we have actually no difference between groups, and you can see that there is a reduction in cardiorespiratory complications in the laparoscopic group, which is significant. Focusing on our post-discharge outcomes, which is the main outcome of the study, you can see that in 90 days after surgery, emergency department visits were not different in the lap and in the open group. And in the most common reason for coming back to the ED was fever or abdominal pain. And 3 out of 4 patients were finally readmitted after emergency department visits. And the rest were discharged home with either antibiotics or only observation. So this is the regression model for emergency department visits. You can see that there is no impact of the surgical approach on the occurrence of the visit, but definitely post-op complications have the most important impact on coming back to the ED. And one of these important variables is actually being discharged with an abdominal drain at home at time of primary hospital stay. And looking at the multivariate analysis, the factors that remain significant are having an infectious complication during primary hospital stay or actually being discharged with an abdominal drain at the first hospital stay. Focusing on hospital admissions, at 90 days, we have around 12% of hospital admission. This is no different between groups. And you can see that the most frequent complication requiring readmission is an intra-abdominal abscess. And this accounts for almost 80% of readmissions. Timing of readmission from discharge was around 2 weeks, the median, and also timing of readmission after initial surgery is 3-4 weeks after surgery, meaning that patients actually come back late. It's not like Whipple's, in which patients actually come back at the hospital very early after the discharge. So what happened during readmission? Most of these patients received antibiotics, and around half of these patients were drained, either percutaneously or endoscopically. Not much difference between groups here. And the length of stay during readmission was less than a week. Looking at the regression model for hospital readmission, you can see that we have no impact of laparoscopy on hospital readmission here again. And again, the complications occurring during primary stay are the ones that determine hospital readmission. And at the multivariate model, interesting to see how we have patients who had with a preoperative physical function which is lower, which are more likely to be readmitted, and also patients who experience a clinically relevant pancreatic fistula or hemorrhage, so important complications, severe complication during primary stay, which are more likely to be readmitted. Well, it was interesting to see that at the univariate analysis, patients who were discharged home by postoperative day 7, so a short hospital stay, was actually a protective factor for readmission. We do have to acknowledge that our study had some limitations, mostly due to the retrospective nature of it, including the selection bias and missing information bias, but also the absence of patient-reported outcome measures, being a retrospective study, which are very important in the post-discharge setting. So finally, in conclusion, we can say that in our study, hospital readmissions and emergency department visits after distal pancreatectomy were not influenced by the surgical approach. Factors that were associated with unplanned readmissions were low preoperative physical status and the occurrence of pancreatic fistula or other complications during primary stay, and the persistence of an abdominal drain at time of discharge. Definitely, those type of patients are the ones that need to be looked after more carefully at discharge, but also our study being retrospective does certainly prompt for a larger perspective multi-center observational study to evaluate better the impact of minimal invasive technique on readmissions. I thank you for your attention.